I'm Dr. Julie Witkowski, and I'm the Medical Director of the Brain Injury Program here at Northwestern Medicine Marianjoy Rehabilitation Hospital. So the patient we're going to be talking about today, he was an 85-year-old gentleman who had a mechanical fall, tripped and hit his head, and was brought to the emergency room by his family. In the emergency room, he was noted to have a subdural hematoma, which is a traumatic brain bleed, and he was transferred to a different hospital for a higher level of care. Upon arrival in the next emergency department, he was noted to have had a neurologic change, and so repeat head imaging demonstrated an acute stroke in his cerebellum. To make his course even more complicated, later on, he was, after being intubated, they did a trial of extubation, and within a few hours, there was concern for an airway obstruction, and the patient actually had a cardiac arrest, underwent CPR and resuscitation efforts, had a fairly quick return of spontaneous circulation, however, needed to be re-intubated. Subsequently, he eventually needed to have a tracheostomy placed and a peg tube placed for definitive nutrition and ongoing respiratory care. He also had another complication during his stay where he had issues with urination and urinary retention. There was difficulty with a Foley catheter placement because he had a history of prostate cancer and had also underwent a prostatectomy in the past. So urology was also called in to do urethral dilation and required a prolonged use of a catheter from that. So after all of that complex course, when the patient was admitted to Marianjoy, he had a number of functional impairments. As a result of his brain bleed and his stroke, he had cognitive impairment, language impairment with both dysarthria and a little bit of ataxic speech. He had truncal and limb ataxia. He had dysphagia, and he also had difficulty managing his secretions, particularly due to some vocal cord immobility from the cerebellar stroke. Due to his complex case, there was a ton of coordination of care involved. While he was at Marianjoy, not only was the rehab team involved with the physical occupational speech therapist, psychologist, and dietitian, we were also coordinating care with other medical specialties. We were coordinating with the neurosurgery team because of his brain bleed, the neurology team because of his stroke, ENT and pulmonology because of his respiratory status and his trach. As I mentioned, the dietitian, but also GI for his peg tube placement, and the cardiology team because of his history of recent cardiac arrest and AFib with RVR. Given the complex nature of this patient case, our team really did need to go above and beyond in facilitating communication with the other specialists involved and also with the patient and his family. As you can imagine, he went through an incredibly stressful experience with all of these medical problems back to back, and the transition to home was a big step for him. We were very excited as a team to gear him up for a discharge to the home setting from Marianjoy, but there was a lot of family training that was involved in that as well. We tried to have open communication, answer all of his family's questions, have them come in for multiple training sessions with our doctors and our therapists and our case managers in order to ensure that when he went home, they were comfortable managing his mobility, his self-cares, his equipment, and also his tube feeding and respiratory status. I think one of the most important things that a physician needs to keep in mind when treating a complex patient like this is that by the time they have probably entered your office or your clinic or your inpatient rehab unit in this setting, this patient and their family member have gone through quite a number of changes that have made their current status quite different than what they were doing before. And this is a perfect example of a patient who'd gone through numerous back-to-back changes, taking him from being completely independent to needing a lot of physical and cognitive assistance. And so when I try to treat patients like this, I, of course, approach it from a physician standpoint and see how can I help them medically. But also it's really important to really get to know the patient, the family, and get to know what their goals are and figure out what we can do between now and then to help them achieve those goals. Now, I've continued to follow him in the outpatient setting for over a year since he initially discharged from rehab. That care coordination has continued for the past year. He's progressed through all of his outpatient therapies. He not only went back to being completely independent in all of his ADLs and IADLs, that means every activity of daily living that he was doing before, he has now returned to. He also went through our Marianjoy Drivers Rehab program, where he was safely cleared to resume driving. And at my most recent clinic visit, we decided to now just check in as needed because he has no more goals he's trying to reach because he's attained them all. In a case like this, one of the rewarding things to see from a physiatrist standpoint is how someone's goals can change as their course of their recovery progresses. So when this patient first came to acute rehab, his goals were to be able to stand, be able to speak. And later on, after he'd returned to driving and exercising and his household activities, but the swallowing function was lagging behind a little bit, his goal was to be able to take a few bites of food. And then later on, his goal was to be able to maintain his weight orally. And then later on, his goals were to just keep being active. Being part of the team that follows someone from beginning to end of that journey can just be so rewarding as a provider.